Right, thanks very much. What we will do, I think, is move on in terms of awareness of the time, and then we can have some questions to cover both of the, or all of these three talks, really, at the end as a panel. So what I would like to do now is talk a bit more about wart treatment, and I gave myself the title of A New Era in Anogenital Wart Treatment, which I think is probably slightly optimistic, but I think it's a good moment to think about this and to talk to you a bit about some developments and some potential developments in treatment, but also a recognition of what we still don't know and the huge gaps that there are. So what I want to talk about is, firstly, sort of where we are now, and then go through a number of aspects of this, including talking about some results of a trial that some of you here will have been involved in, and many of you will have heard about, which is the HIPVAC trial, which has recently completed. So I want to talk briefly about the context in terms of a declining incidence of genital warts. The important problem that we still have a lack of evidence to guide the treatment that we use for genital warts. Talk a bit about recurrence after treatment and the fact that this is still a very common problem following any treatment. A few words about new treatments or the lack of them. And lastly, I want to talk a bit about the potential role of quadrivalent vaccine. So the first thing, obviously, the good news is the decline in genital warts, which you've already heard about. And that is by far the best news around. And particularly in young people, the incidence of genital warts is clearly declining. There was very good evidence in Australia, and we now have evidence in the UK. So it is expected that the incidence of genital warts in the vaccinated cohorts and the younger populations will decline really quite quickly. And therefore, you might say, well, this problem's going to go away, so we don't really need to worry about too much of the rest. Well, it is going to take decades for this to work through to older populations. So I think you and I will continue to see patients with genital warts for some time to come in sexual health clinics. And so I do think we still need to think about how we manage these patients and whether we could do better than we do at the moment. And one of the problems about this is the lack of evidence to guide the choice of treatments. I'm not going to go into huge detail about showing you all of the evidence of this now in the interest of time, but the important question, I think, here is that the two most commonly used treatments that are self-administered, which are podophylotoxin and imicramod, we still have had, even though podophylotoxin has been around for almost 20 years and imicramod for more than a decade, we still have remarkably little data and evidence as to about their relative efficacy and which of these we might better start with and how we might use them. There's also the question of, do you use podophylotoxin cream or do you use the solution? And the data, as you will know, from a number of studies has suggested that the effect was really of these two are very similar, and that probably still is true, although I would point you to a systematic review that was published in STIs last year by Ricardo Werner from Berlin, which does suggest that podophylotoxin solution is probably more effective than the cream if you combine the data from a number of studies which individually didn't show an effect. And so there is now perhaps a bit more evidence to point towards using the solution if all other things are equal. And that's now been incorporated into the latest version of the IUSTI guidelines, which were recently out for consultation. But the other drug, obviously, that we use and have done for some time was imicramod. But there has never been a large randomized trial that has compared these two to give us any idea of really about their relative efficacy. The only randomized trial until what I'm going to talk about in a moment, was this study published back in 2011, which had only 50-odd patients in it, and showed, as you can see, the proportion of patients who cleared genital warts with a solution was 72%, compared with imicramod, which was 75%. But this was assessed at the end of the treatment period, and was clearly very similar. But the problem is that the confidence intervals are enormous because the trial was so small. So this is the only randomized comparative data until some data that I'll talk about in a moment. And importantly, there was no data in this randomized trial on recurrence rates. Because the other aspect of treatment, as you will all be very familiar with, is the problem of recurrence, and the fact that recurrence after treatment occurs in something like 30% of patients, but it has always been said that the recurrence rate might be lower with imicramod than podoflotoxin, or indeed other forms of treatment. But the difficulty about that is that it's always been based on cross-study comparisons. Because of the lack of randomized trial comparing podoflotoxin versus imicramod within a trial, the comparison has always been across trials, and cross-trial comparisons are always fraught with difficulty. And the other data that existed is single-arm cohort-type studies, where, again, you really can't make valid comparisons between treatments. So that's an issue that we thought was an important thing that needed to be addressed. One solution clearly would be if we had better treatments anyway, and one of the new treatments that has emerged more recently, was licensed about 2 years ago in Europe, is one of the synecatechins, or catafen, or polyphenol. But the problem with discussion about where this fits in is that this drug, although recently licensed and clearly shown to be effective against placebo, we still lack data, comparative data, with any of the other treatments. The efficacy looks similar, but it has some disadvantages in that you have to apply it 3 times a day, and it works relatively slowly, perhaps similar to imicramod. But it might be that it has an important place, but we don't know that because we haven't got comparative data. But it would certainly be worth doing trials looking, for example, in patients who failed first-line treatment initially. One of the problems is that at the moment its cost is relatively high compared with podoflotoxin, or even imicramod, now that imicramod is generic. So the question then is, well, we have a range of treatments. We're not very good at knowing which ones are the best, and clearly we could do better and find some more data about that. There are the potential for new treatments, but they're very slow in coming forward. But so another question that has been raised is, well, could quadrivalent HPV vaccine have a role in a therapeutic role in either helping clear genital warts or preventing their recurrence? We know, and there is, we've talked about already, there is ample evidence of its preventative effect, and the quadrivalent vaccine, of course, is the Gardasil vaccine is the only one that contains specific efficacy against HPV 6 and 11. But the question about whether or not it has a therapeutic or recurrence prevention effect has really been lacking. We know that it does seem to prevent reinfection from the clinical trial data, although that's never been what the clinical trials have been primarily designed to demonstrate, because the trials have always been licensing trial to demonstrate efficacy against as primary prevention with a view to implementing the vaccine in adolescents before exposure. But there is some evidence for that, and there's also at least anecdotal reports of responses in genital warts or in patients with laryngeal papillomatosis, a severe condition with persistence of HPV 6 and 11 types in young children. So it's on the background of this that we obtained funding, and many of you here will have, I hope, will have taken part in this study and certainly have heard about it. We had obtained funding now an embarrassingly long time ago, because it's taken a long time to deliver the results of this trial. We obtained funding to do a trial to compare imicramod versus podophyllitoxin, and at the same time compare the effect of HPV vaccine against placebo in patients with genital warts. So the trial objectives were to compare the efficacy of these two standard treatments, and we chose the cream in both cases, imicramod and podophyllitoxin, and as I say, the quadrivalent vaccine against placebo. So what I thought I would do is to tell you a bit about some of the results that are now emerging from this. We presented the sort of headline results of this trial at the papillomavirus conference in the autumn, and we will be presenting more of this data later in the year, but I thought this might be a useful time to discuss some of this, at least the highlights of summary. But to just explain a little bit more about what we did, for those of you who are not already very familiar with this, was that we conducted a multi-center, it was a partially blinded factorial design study, and the criteria were very open. We hoped that this would be as representative of patients attending sexual health clinics with genital warts as possible. So essentially it was any patients attending the clinic with new or recurrent anogenital warts. The only exclusion was people who had been treated in the last 3 months, because we didn't want to simply have a trial with patients with failed wart treatment. And the only criteria in terms of the vaccine was that they shouldn't have had quadrivalent HPV vaccine in the past, but that wasn't a problem given the age range and timing of this. And the topical treatment was imicramod given according to the license for up to 16 weeks, or podophyllitoxin given initially for 4 weeks, which of course is the license, but we know that people frequently continue podophyllitoxin application beyond that, and so we allowed investigators to continue treatment for up to 16 weeks, but we also allowed investigators to add in cryotherapy if they felt they really had to. We strongly encouraged them not to do so before 4 weeks, so that we could get a valid comparison at 4 weeks of podophyllitoxin versus imicramod. But after that, we did allow cryotherapy, mainly because we thought it would be difficult to keep people in the trial if we didn't do that. If we lost a lot of patients, we wouldn't have a valid result anyway. So that was a sort of compromise. But the proportion of people who had cryotherapy was actually lower than we thought. It was about 20% overall. The vaccine was the Gardasil, and we had a saline as control. And the endpoint of the trial was a composite primary endpoint, because we wanted to combine or detect an effect on the combination of both clearing the warts, but also remaining clear at 48 weeks. Because that, at the end of the day, is what patients are interested in. They want to know whether the treatment will work to get rid of their warts, and they won't have warts in a year's time. So we think that's a relevant clinical endpoint from the point of view of the patients. And because of the nature of the trial, and there were quite a lot of complexities in its design, the analysis was by logistic regression, and because we knew that there was going to be a potential problem of people dropping out, we built into the design of the trial that we would use a statistical technique called multiple imputation to allow for the fact that there would be missing values. And if you model the results within a trial, you can effectively fill in some of the gaps, which reduces the bias associated with loss to follow-up. We planned initially to recruit 1,000 patients to this trial, which was always going to be a challenge. It turned out to be too big a challenge for a host of reasons, which I could certainly write a book about. So we had to accept that within the time constraints and the funding constraints, we couldn't run to the full 1,000 intended. So we eventually agreed to stop the trial after 500 patients. But this is still the largest clinical trial that there's ever been in this condition, and one of the largest randomized trials in STIs that there has ever been. So this was again, to just remind you what I've said about the design. So patients were recruited to the study with genital warts, and at baseline they were randomized to either imicromod or podoflotoxin, and they were at the same time they were randomized to receive either vaccine or placebo. And they were then followed up over time in these arms. If they were on imicromod, they just continued on imicromod as long as they had warts, and they stopped when they had cleared, but continued up to week 16. If they were on podoflotoxin, they were allowed to extend that up to 16, and as I say, they were allowed to add in cryotherapy if otherwise they were likely to have been lost to the trial or removed from the randomization. And at 16, which was the primary, a part of the primary endpoint of the study, clearance at week 16, after that, if they still had warts, then at the investigator's discretion, they could have whatever treatment. But they continued in the trial because they had a third dose of vaccine, and then we followed them up to week 48 to see what proportion of people had remained clear at the end. And so this was very briefly the summary of the characteristics of the patients who were recruited to this study over just over a 2-year period. The last patients were recruited at the end of 2017 or beginning of 2017 and finished their follow-up at the beginning of 2018. And so this is the analysis at the end of the trial. So we recruited 500 patients, almost exact distribution between the 4 groups, imicromod plus vaccine, podoflotoxin plus vaccine, imicromod plus placebo, or podoflotoxin plus placebo. And they were very well matched across, well, the randomization. There was some stratification involved to ensure that there weren't major differences, and that all worked very smoothly. And the characteristics of the population were very much the characteristics of the sort of population that we all see in the clinics. And to jump straight to the main results of this study, and then I'm going to talk a bit about what we can conclude from this and summarize at that point. So the main, the primary endpoint of this trial was as I remind you, was a combined primary endpoint of both being clear at week 16 and remaining clear at 48, and the adjusted odds ratios for this effect using the analysis that I've described with multiple imputation showed that in a comparison of imicromod versus podophyllatoxin, the adjusted odds ratio was 0.81. So what that means is that imicromod was perhaps slightly less effective than podophyllatoxin in this combined primary endpoint, but that the confidence intervals were well either side of 1. So there was no statistically significant difference between imicromod and podophyllatoxin in this combined primary endpoint. The vaccine effect, so this was vaccine versus placebo, the adjusted odds ratio for this combined primary endpoint was 1.46, suggesting that the vaccine was more effective than placebo, but the confidence interval just spanned 1. And those of you who are familiar with running clinical trials, this was a rather frustrating result, because clearly if it had been a tiny bit higher, we would have been more confident of our result. But it certainly suggests that there is some evidence there that the vaccine has an effect, but it does not meet the standard criteria for confirming efficacy. But and that's based on, obviously, a trial that was half the size of the trial that we were hoping to have done. If you split this out in terms of the effect at clearance at week 16, and then look at just the recurrence rate, what you see is that the effects go in the same way, which gives us a bit more confidence that what we're seeing may be real. So the imicromod versus podophyllatoxin, again, the imicromod perhaps slightly less effective than podophyllatoxin, but with confidence intervals spanning 1. The vaccine versus placebo, the confidence intervals obviously are wider because you're dealing with a smaller group here, but it's still more than 1. So 30% higher in the vaccine group versus placebo, but not statistically significant. If you look at the effect on recurrence, it's also going in the same direction. There's really no difference between imicromod and podophyllatoxin on recurrence rate, albeit the fact that the confidence intervals are quite wide. But the effect of vaccine is again in the direction of a positive effect for vaccine, but not significant. So, if you look at this just as a survival analysis, which is another way of presenting this data, this is the Kaplan-Meier survival estimates for walk clearance. And so what this shows is that by about week 16, here, about 50% of patients had cleared their warts, which is just about what multiple studies have shown and the systematic reviews suggest, and it's exactly what we predicted was going to happen in our sample size calculation. But it does, and the difference between these lines is obviously not statistically significant, but there's some suggestion that the vaccine group might be doing slightly better. And then this is the recurrence rate in those who have cleared. Again, and what it shows that of those who cleared and then were followed up, about a third of patients by the end had relapsed, which again was overall what we were expecting, but that there was some suggestion that the vaccine group was doing better than the placebo. So what can we conclude? And do we have a new era in wart treatment? Well, we have produced some evidence to suggest that there may be a vaccine effect, but it's clearly not statistically significant, but it's going in the same direction, both in terms of the combined endpoint and the individual. The imicramod and podoflotoxin had really very similar efficacy at week 16. The efficacy after 4 weeks of podoflotoxin was substantially worse, significantly worse, I'm not showing you the details, than imicramod at 16 weeks. So there's no doubt that it's well worth continuing podoflotoxin beyond 4 weeks, and that stopping at 4 weeks, it would certainly be inferior to 16 weeks of imicramod. So